trying to decide whether it's low turnout or late arriving crowd. It happens both ways. So good afternoon and welcome. So good to see all the familiar faces, and thank you for supporting this activity each month with your attendance. It means a lot, makes a lot of difference to all of us. It's been a busy season, hasn't it? And a fun time. I hope everyone's enjoyed the holidays. Yes, I knew there would be stragglers. I knew there would be stragglers, but Doris, I didn't expect it to be you. Well, so good to see everyone. As you know, I'm sure virtually all of y'all know, but it bears repeating, we do this presentation, You and Your Health, once a month. And it's specifically picking a topic that's likely to have an appeal to you that has to do with health and aging. So often diagnoses or conditions that are more common as we get older, or simply have interesting differences with age, and I think that fascinates all of us. So today, I realize we've never really done one on dermatology, on the common changes that happen with our skin. Increasingly noticeable, right? That's, gosh, I wish I could make aging changes go away in the skin. I would be independently wealthy, and I'd still be here, I promise, but I'd have different worries. But so the common normal changes with age, and then of course the common abnormal things that happen between rashes and skin conditions and then the lesions and different tumors and things. Thought it might just be helpful, and people would find it interesting to have an explanation for a lot of these, so you kind of recognize what you're seeing. I tell people all the time, I probably told one of you or more, we all get more barnacles with age. and I'm sure no one's going to jump up and want to pull their shirt up and show the barnacles on my back. I won't do that either, I promise you. But anyway, they're going to try to improve our understanding and perspective on all of this. We have had such a great experience this block. So typically, they are giving this presentation on the last Wednesday, the last week of a 4-week block here at Butterfield Trail. So we've enjoyed having them here. These are two most conscientious resident physicians that are with us, and as you know, they're doing their residency in internal medicine. So they've just recently, a year or two before they get here, they've just received their medical degree, and now these are the 3 years that will make them, will lead to their being a qualified internist, internal medicine specialist. And then they can either start practicing. More and more of those practicing are doing hospital medicine, what we call a hospitalist. I hope more and more will be doing primary care too, outpatient medicine. And then they do have the choice of going into a medical subspecialty. So you can think of all those ones that aren't surgical but are medical subspecialties like cardiology and gastroenterology and nephrology, and there's a dozen of these. So anyway, it takes 3 years of the residency to prepare them for that. So who's going first, by the way? Okay, Dr. Chapman, Christina Chapman. Christina, you're our second year resident in our program. She grew up in Fort Smith, correct? And went to Washington University, a fairly regarded school up there in St. Louis. So highly regarded. I told her the last time I was on the WashU campus, there was a kid wearing a T-shirt that said, "Harvard, WashU of the East." But I'm sure they don't have any kind of elitist attitude there, right? No, absolutely not. So Christina's in her second year, and with her, Dr. Rachel Graham, is with us, and she grew up in North Little Rock. So these are two Arkansas girls, and went to the University of Arkansas. Both of them got their medical degrees from Uams. So these are homegrown and educated ladies, and both just very sharp and fun to work with. So without further ado, I'll hand it over to Dr. Chapman, and she's going to educate us about the skin.
Hi, everybody. Thank you for that introduction, Dr. Wright. It's very kind. So we're going to do our best in this presentation today. So I'm going to kick us off. This is just a little bit of an overview of what we're going to discuss. So first, we're going to talk about some normal changes that we see in skin and hair with aging, and then some common problems, including photoaging, inflammatory and autoimmune conditions, infectious skin findings, benign growth, and skin cancers. I'll be doing the first half. So first, just talking about normal aging of the skin. So the epidermis, which is the outermost layer of the skin, as we age, tends to thin out, and it loses elasticity and makes it much more fragile. And so you can find more easy rips or, abrasions. If you fall down, it's more likely to remove parts of your skin. There's also a slower rate of wound healing, and this is due to a slower turnover of those cells. We have reduced immune surveillance, which also involves, decreased wound healing, and that's because our immune cells are just less present in the skin as we get older. And we have decreased sensory perception in the skin as we age due to the decreased, basically the components of the skin that causes us to sense things is decreased in number. As far as the hair, graying hair, so that is because of melanocytes. So as we age, we have decreased melanocytes in our hair, and these produce melanin, which is the pigment that we find in our skin and our hair. So that's decreased. We also have decreased scalp density, hair density, because of just decreased growth from follicles over time. Now talking about photoaging, which is probably the number one cause of increased aging look of skin. So exposure to UV light is the largest contributor to the aging of skin. So in UV light, what it does, it increases cell and DNA damage, decreases collagen production, and cutaneous malignancies. So common leading factor in malignancy and cancers. So a little bit about this.
You want to mention what UV light is, or the sources?
Oh, sure. UV light, so primarily from the sun, just a certain, in the spectrum of light, primarily the primary source is the sun, essentially. So clinical appearance, and I'm going to show some pictures of a few of these things. Lentigo, these are also known as liver spots. They are flat spots that are darker than normal skin tone. I'll just toggle back and forth so I could show you a picture. That top left, that's lentigo. Guttate hypomelanosis. So this looks like small whitish flat spots. I looked this up myself because I wasn't exactly sure what guttate meant, but apparently it relates to droplets. It means looking like drops. So if you see in this bottom picture here, the white spots that are widespread, kind of like drops on the skin, that's what that is. Come back. Poikiloderma. So this is areas, it's a little bit of a mixed picture. You can have hyper and hypopigmentation, so darker or lighter color. Telangiectasia, which is essentially spider veins, and atrophy of the skin, thinning of the skin. So here is a picture of that on the upper right. Mostly you can see the hyperpigmentation, the darkening of the skin. So these are common findings of photoaging. You can also see laxity of the skin, increased sagging, looseness, a yellow hue, a yellow tint to it, and sometimes a leathery appearance. So all these are common findings. Okay, now prevention. So this is important for us, right? So of course we're going to recommend sunscreen. Anytime you have sun exposure, sunscreen, and avoiding direct sunlight if you can, particularly in the midday sun for the most UV light. Protective clothing, hats, sunglasses, etc. But then once you have it, of course, you're going to want to treat it. Well, of course, all of us. Most common or the most effective treatment is this topical agent called tretinoin. Essentially, it's a retinoid agent that's often prescribed by dermatologists, and it's just some of its effects. It increases thickness of the superficial skin. It can reduce pigment changes and increases collagen synthesis. There is some evidence that topical and oral antioxidants can have some effect as well, vitamins E and C, but primarily the tretinoin is the one that's proven to be effective. And then there's more advanced techniques and surgical procedures. So they're chemical peels, dermabrasions, lasering resurfaces, etc. But those are more advanced and practiced by dermatologists. And again, essentially how these work is it disrupts the skin surface and removes the damaged skin off the top layer. And so new cells from the bottom, from the deeper level that has not been exposed to that UV light, can surface and it will be healthier and less damaged appearing. Essentially how that works. I stole this picture, but this is a little bit overview. We're going to talk about inflammatory and autoimmune conditions now of the skin. I thought this was just a little funny cartoon, basically showing inflammation, a joke about inflammation. Let's talk about a few issues here. We're going to start with seborrheic dermatitis. This is a very common condition. This is a little bit of a picture of how it looks like, but just to describe it, you can get these red patches with an overlying greasy appearance where sebaceous glands are found. So some of those areas are scalp in the face, presternal, so on your chest, and where skin rubs together, any skin folds that you might have. Apparently it is prevalent in Parkinson's disease in particular. I wasn't aware of that, but apparently so. So the cause is unclear. Now, per this report, they're saying that normal yeast flora may cause some inflammation that might lead to these findings. And that's one ongoing hypothesis. And sometimes if you have immunosuppression, so if you have HIV or if you have or being treated for any cancers or some kind of like that, you might find these and you might have eruptions of this as well. So treatment can be treated but not cured, unfortunately. Mostly just a little bit of an overview. Creams, topical agents, creams, shampoos are most often prescribed. There are medications, particularly those that target the yeast because they think that might be causing it, and those are listed there. And occasionally you can use steroids or immunoagents as listed here for acute flares without going into too much detail on that. Second condition I want to talk about is rosacea. So now this is a little bit of how it can appear in a picture there. You can see widespread redness, red bumps, papulopustules, which is basically bumps that can contain pus. That's what that means, which can be found in the cheeks, forehead, and the chin, so like this man here. Now, in this condition, you can also see a thickening and a little bit of a growth changes of the nose. They call this a rhinophyma, which is essentially a bulbous nose. So if you see somebody with a little bit of a disfigured nose with abnormal growths, this might be a rhinophyma. And sometimes it can cause redness, burning, and itching of the eyes as well. Guys can be involved.
Think W.C. Fields on that nose. That's due to rosacea.
didn't get that reference, Dr. Rye. Maybe you aged us there.
They're too young to know who W.C. Fields is.
Sorry.
I'll-
I will. I'll have to. I want to be in the know. But so apparently, common and fair-skinned people in particular can affect all ages, but apparently it peaks in the third and fourth decades. So again, they think the cause is multifactorial, and so I'll just kind of go through a little bit about what can cause it. They note vasodilation, which is basically the dilation of blood vessels, so more blood flow to parts of the face, scalp, wherever you might have a flare. Now, they mention also these mites, Demodex mites, and this bacteria that inhabits some people's hair follicles or sebaceous glands that might lead to some of these as well, this immune reaction. Thermal stimuli, heat, cold, sunlight exposure, different diets, and different medications. There's a whole list that in certain individuals can trigger events, these breakouts.
I think what's fallen off that list over my career is alcohol. Probably because of the W.C. Fields effect. Everybody was sure that alcohols had something to do with it. So.
Now that you say that, I do think I remember hearing that correlation, but yes, wasn't listed there. Now, treatment, there are different subtypes, but mostly it's topical agents or sometimes topical or oral antibiotics, like listed here. They do have alternate therapies listed. They note retinoid therapies, the tretinoin and the isotretinoin for severe cases. Again, that's all retinoid, like retinol. Sometimes laser therapy. And the rhinophyma, mostly that's a surgical treatment. Okay, the next thing, so pruritus was on the list. Now, pruritus, what this means, its definition is basically itching, which is could be many different things. But just to note, as we age, itching can become very severe and can very much compromise quality of life. So here, extensive differential diagnosis. There are many causes of this, notably dry skin. I think that's probably one of the most common. Then have a whole list, allergic, irritant, different dermatologic conditions here. Won't go into detail about all of these, but different dermatitises, and then more general other chronic health conditions, renal disease, liver disease, thyroid, occult malignancies even, drugs, and of course psychiatric is kind of in the bottom of a rule out cause of pruritus. Okay, so of course now treatment of this, you want to find the cause and treat the cause. That's primary goal, but of course you also want to provide symptom relief if you can't find the cause. And so some of the things that we typically prescribe are topical corticosteroids very often, or other things to give symptom relief like emollient. Thank you. Essentially provide more moisture to the skin. If you have dry skin, will definitely help the itching. Yes, they also mentioned this open wet dressing for evaporative relief, meaning feel the sensation of water evaporating off of you might help as well, which I thought was pretty neat. I might have to try that in the future myself. They listed some other things that are a little bit off-label, like oral antihistamines. We typically don't want to use those as first line just because there are some negative side effects of those things. But if it's a refractory to all these other more readily available things, we might go there. Okay, next I want to talk about psoriasis. So now there are many types of psoriasis, but the most common is these chronic plaque psoriasis. This picture is showing this. It can involve the scalp, the gluteal cleft, or extensor surfaces, such as elbows, knees. There are other types, and I just kind of mentioned them, not to dive into them too deep. Inverse pattern means that these plaques are most commonly found in skin folds, so armpits or wherever skin is folding together. Guttate, like I said, the drop-like appearance. So the similar have little red spots in a drop-like pattern across your body. Pustular, so creates pustules. Yes, and so then there are these other rare kinds. Palmoplantar, which is basically on the palms and soles. And erythrodermic, just a general redness across the body. But by far the most common is the top, the plaque psoriasis that's pictured. So a little bit about it. It affects about 2% of the population. It has a bimodal distribution of incidence, which means it can peak in 2 different periods of life. Typically, it starts in the mid-20s, but there's also a secondary peak of incidence in the 50s and 60s, so it can really start anytime. So most people have some kind of genetic predisposition, but environmental factors may contribute. And sometimes there's a triggering event, like an illness or a trauma, life stressors, medications, very common. And there's a whole list of possible medications. And also, this can be commonly associated with psoriatic arthritis. So the typical arthritis symptoms associated with this rash. Now, treatment, most notably, I saw the lifestyle modification. And this is a little bit, I don't know, you don't initially think about this, but the reason why is because with psoriasis, you can get widespread inflammation of your body. And when you have an inflammatory disease, it puts you at increased risk for cardiovascular events. So the reason why they say lifestyle modification is because of this cardiovascular risk in these patients. So diet, exercise, weight control is important to prevent any cardiac events. But for the rash itself, topical treatments is normally the way to go. So corticosteroids, vitamin D, retinoids, again. So we kind of see a little bit of a trend. The retinoids keep coming back as well. And again, you want to avoid long-term corticosteroids, and that's just for everybody. But especially and topically, it can lead to skin atrophy or thinning of the skin as well over a long course of time. So you don't want to use it over and over and over again. But short term, it's okay. And these are kind of alternative things. In this patient, they mentioned UV therapy can use if it's refractory to the other treatments. And sometimes you can give systemic treatment, which means oral medicine that's going to go across the whole body versus just a topical medicine, if there's no response to these other options. Okay, and last but not least on the immune side here is stasis dermatitis. So this is an early sign of chronic venous insufficiency of the legs. So really what this means is that our body's not doing a good job pumping blood from our legs up to our body. So venous insufficiency, the veins aren't helping us pump it back up. So we get a pooling of blood in our legs and increased pressure in our vessels in our legs. So what this can lead, we can see this primarily in the skin above our ankles, and it can lead to redness and swelling of the legs, and sometimes itching, and it can risk ulcers forming in that area. So we treat it by trying to relieve some of the swelling, essentially. Compression, bandages, stockings, raising our legs, calf muscle exercises to improve venous return, and yes, again, topicals as well to help with the symptomatic relief. Okay, that's my side. And now here's Rachel. Dr. Grant.
Thank you. Okay, so now we're going to move on, let me get my bearings, to different infections that you can have in your skin. So we're going to cover 2, herpes zoster and candidiasis. So herpes zoster is caused by the varicella zoster virus. That's the same virus that causes chickenpox when you're younger. So as we get older, that virus, it can live in your body and it reactivates, which is what causes shingles in older adults. So more than 2/3 of the cases occur in people who are older than 50. The general population has a lifetime risk of reactivation of this virus that's 20%. But if you're immunocompromised, then that can be increased to 50%. And it can be reactivated when there's a decline in our immune response. So that could be if you become immunocompromised, or it could just be the general decrease in your immune system as you get older. The way that this typically presents is there's an area that will feel painful, and then a few days after the pain is when the skin eruption will start. So this is known as a very painful infection, and typically you'll see those vesicles, those little bubbles, they will be in a line. We call it a dermatomal distribution. So it might be like one area of the face or one side of the torso, and it'll be in a line like that. So there are some complications with this, mainly when it involves the face. So there's Hutchinson sign, which is when you can see it on your nose. There's also Ramsay-Hunt syndrome, which is when you see the vesicles or those bubbles on your ear. And those areas are typically, first of all, more sensitive. We have more nerve fibers there, so it can be more painful, but there's also a higher risk of long-term effects, such as impacting your vision or impacting your hearing. And then another complication is postherpetic neuralgia. So neuralgia means pain, so pain after having the infection. It can last for the rest of someone's life. We diagnose it. You officially have postherpetic neuralgia if it's been 4 months since you had the inflammation and you're still having that pain. It occurs in 20% of people who have this over the age of 70. And then the older you get or the more immunocompromised you are, the more likely you are to have this lasting effect. So there are treatments. Those 3 medications listed on that first bullet point are all a pill that you would take that helps to fight this infection. And it's important, it's ideal to start within 72 hours of having this rash. So if you remember this lecture and later you're like, hey, I think that I have this, or one of your friends says, look at this rash that I have on my arm, call us, come into the clinic, because within 72 hours is when we would like to start that. And most cases are self-limited, meaning that they will resolve on their own. So that sounds pretty awful. I'm sure most of you don't want to get it. The good news is that we do have a vaccine that can help to prevent this. It's called the Shingrix vaccine. It is 2 doses, and you have to get them a certain amount of time apart. So if you haven't gotten it yet, or you haven't heard from us that you need it, you will be hearing from us at your next appointment. So now whenever they say, oh, have you had your zoster vaccine, or have you had your Shingrix vaccine, you'll know exactly what that is and why it's so important to get it.
So just to be clear, I think you probably all know, but if you weren't familiar with that term, herpes zoster, everything that Dr. Graham has talked about is shingles.
Yes, sorry.
Talking about shingles.
So the
and I
virus.
think most of you have had the vaccine by now. So the new one, the two shot thing, to this point they've indicated it's lifetime, but they've done that in the past and then come up with another one, so I can't promise.
Yeah, so varicella zoster is the name of the virus. In younger people, it causes chickenpox. Older is shingles. Okay. So a different infection that you can get is candidiasis. This is a fungus or a yeast. It's cutaneous, so it's on the skin, and you can often see it in skin folds. So it can affect the nails, the scrotum, genital area, corners of lips, and it's a rash that will be red patches. Sometimes it'll be raised. Sometimes there will be those pustules that Dr. Chapman was talking about, the little bumps that can have pus in them. But pretty much always it's going to be red, like in that top picture. That is on the skin. You can also get oral thrush, which is candidiasis of the mouth. So this is really common if you use inhalers. So when people use inhalers and then don't rinse out their mouth afterwards, then it can cause that. Or use of antibiotics, if you are immunocompromised, anything like that can put you at risk for developing oral thrush. There's no pain associated with it. The only symptom is that your tongue looks white like that, but that can help us to recognize it and then go ahead and treat that infection. I'm not patient enough, sorry. Okay, so the treatment for this, we do have topical agents that we can use, or if it's a widespread infection, then we will do pills that are more of a systemic approach. And then if it is a moist area that continues to get this infection, then it's a matter of treating the root cause and making sure that those areas stay dry. Candida or candidiasis is also what causes diaper rash. So folds of skin. Okay, next are benign growths. We get a lot of questions about these in clinic because these new things appear and everyone wants to know, is this something I should be concerned about? Is this not? So benign are things that we don't necessarily need to be concerned about. So the first is seborrheic keratosis, not to be confused with the seborrheic dermatitis that Dr. Chapman was talking about. So they can be raised, they can be waxy, they might have a tough texture. They're typically dark in color. They can grow over time. You'll get new ones throughout your life. They might fall off and then grow back. These are those barnacles that Dr. Wright was talking about. Next is cherry angiomas. They're those red spots, also benign, and they're the most common that we see as we get older. So they can be round, they can be oval, most of them are bright red, and it's kind of a raised dome-shaped papule, almost like a cherry, which is why it's called a cherry angioma. But these are just composed of dilated capillaries and blood vessels, basically. So they're just dilated, they're clumped together. They can be removed if desired, but there are so many of them that we develop throughout our life that most people don't want to get cut that many times, and I don't blame them. Next is actinic keratoses. So these in and of themselves are benign, but they are one of the main things that we look for. It can be rough and scaly, it can be reddish or brown in color, and it appears on areas that have been exposed to the skin before. So the reason that we look out for these is that they can turn into cancer. So we like to find them whenever they're like this, just little rough patches, and go ahead and treat them so that then it doesn't become a problem in the future. So like I said, they're pre-malignant. Up to 20% of them can progress to squamous cell cancer. So if you've ever been at the dermatologist and they have the nitrogen spray, it almost looks like a mini fire extinguisher. They can freeze them off like that. There's also topical 5-FU cream that they'll use. That is especially for men who are maybe balding, so they have a lot of area on their scalp that could have these. So it's easier to just treat that whole area with the 5-FU cream as opposed to freezing all of those, since the freezing can get a little uncomfortable. So that is the last of the benign growths. And then now we're on to the malignancies. So we have basal cell carcinoma, squamous cell carcinoma, and melanoma. So basal cell carcinoma, these are typically raised lesions, like you can see in the picture. It often is eroded in the center, so the center kind of divots or indents, almost like a donut. and then it has a rolled border on the outside. So it's rolling in. It almost looks like you could just pick it up. So it's the most common cancer in the United States. The good news is that it doesn't metastasize very frequently, so it's not as likely to spread to other parts of your body. Risk factors are increased age, UV exposure, immunosuppression, genetic syndrome, as well as exposure to chemicals. The treatment for this is to remove them surgically. If surgery isn't feasible, then you can use ablative methods such as freezing, cryosurgery, radiation, things like that. But ultimately, the most effective is just to remove the lesion altogether. Next is squamous cell carcinoma. This is the second most common form of skin cancer. Once again, associated with sun exposure and age, and it commonly occurs in the areas where you receive a lot of sun exposure. So such as the top of your head if you are losing hair, or your hands, or the face, things like that. So this one can be locally invasive, so it is more likely to spread to other areas. And it's more likely to occur in areas that are wounds that are not healing very quickly, burns, scars, things like that. So if you have a scar, especially in a place that can receive sun exposure, and you start to see a little bump like that forming in the scar, that's definitely something to alert either us or your dermatologist about. So the bumps can occasionally be tender. It's going to be erythematous or red. It's going to be a papule, meaning that it's raised, or a plaque or a nodule. And it might have that crusting, that roughness on top as well. The treatment for this is also surgical excision. There is Mohs surgery that is a specialty that dermatologists can do, where they go in and they slowly slice the smallest amount of skin needed to be removed. So that can be very helpful in areas where the scar is more likely to be seen, such as on the face, on the nose, things like that. If they're not able to do surgery, then there are other options such as radiation, but once again, it's just not as effective as completely removing the lesion. So, last but not least is melanoma. It often presents as a mole, just like that. It has irregular variegation in pigment and irregular borders. So that's what makes us think melanoma versus a mole. And it is a malignant tumor of the melanocytes, which Dr. Chapman was talking about. Those are the cells that produce the pigment or the color in our skin and our hair, things like that. If you're going to take one thing away from today, this is it. Whenever you are getting out of the shower, applying lotion, looking at your skin, this is how you can tell if it is a mole or if it's more likely to be melanoma, and you should get it checked out. So the first thing that we look for is asymmetry. If a mole is pretty circular, then it's more likely to be a mole. If it's very irregular or asymmetric, then it's more likely to be melanoma. And then same with the border, if it's an irregular border. Color. So color doesn't necessarily mean, oh, I have this mole that is light in color, but then this one is darker than that one, so it must be melanoma. It is a difference in color in the mole itself. So when you're looking at the mole, if there are lighter pieces and darker pieces, that's what they mean by changes in color. Diameter. This isn't necessarily the size of the mole, is the mole changing in size? So if it's a larger mole, but it's been the same size your whole life, that's less concerning than a mole that you've noticed is growing and becoming bigger in size. And then same with the next one, evolving. If it's changing in color, if it is changing in size, if the borders are changing, those are things that we want to look out for and be aware of. So it's so important to treat melanoma early and to find melanoma early because it's the one that is the most likely to spread to other parts of your body and to have that metastatic cancer. So the incidence or the amount of people getting melanoma is increasing. Risk factors for this are if you have fair skin, if there's a strong family history, if you have red hair, or a history of a lot of moles, as well as exposure to sunlight. Early detection is key for a higher rate of cure. So you can increase the likelihood of early detection by doing regular skin checks. This can be an annual skin check with a dermatologist. It can be you checking yourself anytime you do put on lotion, things like that. And then there's the ABCDEs again. So asymmetry, is the border irregular? Does it have different colors in it? Is the diameter over 6 millimeters? And is it changing? Is it growing? Is it changing color? The treatment for the melanoma really depends on how aggressive the melanoma is. So they measure and see how deep into the skin it goes, and then from there they can determine if they just remove it off the top or if further excision is needed. So like I said, this one has the highest risk of metastasis. It can metastasize or spread to other areas of the skin, the brain, the lung, the liver, and the small intestine. Risk factors for it spreading are the depth of the invasion, if it's just on top versus if the melanocytes go further into the skin, if there's an ulcer, and then the number of mitoses, so how rapidly these cells are dividing and growing. There are several different types of melanoma. The most common is the lentigo maligna. That's going to be on sun-damaged skin. There's superficial spreading that we've talked about. Those are the more flat, almost like freckles. Nodular is more like a typical mole where it's raised. And then there's acral lentiginous. So this is more likely to be found on the soles of the feet or the palms of the hands, and it is more common in patients with darker skin. And then here's a picture of what that acral lentiginous melanoma looks like. So more likely to be found on the soles of the feet and the palms of the hands. So in summary, the incidence of skin disease increases as we age and increases as we get more exposure to UV light. So the dermatologic care of our geriatric population requires knowing about these things, knowing about the common tumors, knowing what to look for, so that you guys know when you need to come see us. All right. What questions do you guys have?
Good. Well, that's a lot of information, a lot of pictures, and
Yeah, now
can
you
make
get
your-
to take a quiz.
yeah, can make your head spin. See, I'm sorry.
Approximate size of the 6 millimeters.
I think it's a pencil eraser, right?
So that would be about 1/4 of an inch, wouldn't it?
Mhm.
Something like that. Yeah, pencil eraser. Yes. Yes. Robin has it, and we'll print it out for you if you just drop by the clinic and tell her you want it. That's a good idea. You know, I'm surprised no one has asked, and I know you're going to ask it. I'll just go ahead and bring it up. Even though it's not a skin disease, people are concerned about it. And so as we get older, and you saw in her first slides about thinning of the skin is one of the normal changes with age. Among the things that makes you prone to, if you're on aspirin or something or a blood thinner, is the dark splotches that look like bruises. The technical term would be purpura, kind of like purple, but purpura. These are these dark patches. They're not harmful. They don't lead to problems, but it's easy to understand why they occur once you've heard the explanation. The thing that is being lost in the skin, and why isn't it everywhere, is what I'm thinking, since I'm carrying extra weight, but it's the subcutaneous fat in the skin that thins out and leaves our skin being so thin. It's that subcutaneous fat. I mean, it's part of a big part of what's thinning out anyway, but that subcutaneous fat is also what gives the tiniest blood vessels, the capillaries, their support. They don't have a membrane around them, but what holds those blood vessels together is what's the very thing that's being lost. And so it doesn't take as big a blow or scrape to cause you to bleed under the skin, but especially if you're on aspirin. So that's really the reason for it, and it's alarming if you've never had it, because it's so different, but it's benign. So, yes.
I know some dermatologists suggest an over-the-counter product called Differin Gel, I think it is, to deal with blotches and so on. Do you have any thoughts about that?
You've introduced me to a new, I haven't seen that.
I need to look up what the active ingredient is in it. I don't recognize the brand name of it.
Does it work? Okay. You're looking for another endorsement before you step out there. I don't blame you. I'm not familiar with it, but the specialties come up with new things. They should be on the cutting edge end of their specialty, and if there's a dermatologist really actively promoting that, it probably has some studies that show. Yes.
Dr. Wright, sorry, I have an answer to that question.
Okay.
So the active ingredient in the Differin Gel is retinoids, which is another derivative of vitamin A, which is also what that tretinoin cream that Dr. Chapman was talking about is.
Okay.
So,
It may be a new formulation of what is medicine that's been around for a while, but it may work better in this formulation. I'm not sure.
You mentioned the vaccine for shingles. She didn't want it.
You didn't want a mic?
I don't need a mic.
No, it's the people without hearing like me that need you to have a mic.
You listen and you'll hear. You mentioned old and new. Those of us who got it when it first came out, we are in the old one. When do we get a shot then?
Oh, and you're talking about the Zostavax,
Oh,
the Shingrix. I think if you had the old one, is the only one you had?
I had one when it first came out.
Yeah. Then you're way overdue to get the second one.
I got two at the time.
Well, then you got the second one. You didn't get the first one. If that's the only one you got, your first is, so you don't have to go back and get the first one. Hallelujah. I'm glad you brought that up. I hadn't thought about that, of course, being confusing. Yeah, I got my first one, and it wasn't 2 years before they're saying, no, that's not good enough. So I bet that happened to a lot of us. But thanks for pointing that out. Yeah, if you've had the two, you don't need the first one. If you had the first one, you still need the two. Okay. Other questions? Oh, I'm so sorry. You're in my blind spot.
I got some Differin. It was a get from a doctor, and I just felt like it wasn't doing anything, and I just quit using it and went back to tretinoin.
It is a lower percentage since it's just over the counter as opposed to a prescription. It's a lower percentage of the vitamin A derivative.
I felt like it was a waste of effort.
Well, you already know this, but to point out the obvious, if it's over the counter, it's probably less potent. Doesn't mean it won't work for you, but once they get to a certain potency, there's a tendency for it to be prescribed. Yes.
How long ago has it been since the second shingles shot came out?
I'll look it up.
Say that again.
How long has it been since the second Shingrix shot came out?
Probably 5 years. 5 or 6 years ago. Yeah. I'd say it'd be 5 or 6 years.
October 20th of 2017.
Okay. You're due. Dr. Helen.
No, I've got a microphone.
Good. You don't need to.
Well, I understand that your major emphasis was on the diseases of the skin and the pathology. I'd like to get a little practical because as we age, we have to be more concerned as senior citizens as to taking care of our skin, what's happening. So my practical question is this. How many baths would you recommend under normal circumstances, and I'm talking about you not getting really dirty for some reason or perspiring a lot, how many baths would you recommend to senior citizens under normal circumstances, and why?
Go ahead.
Per week, yeah.
Have an opinion?
Last
I'm sorry?
Last I read, it was every 2 to 3 days, depending on how dirty you get. And it's important to reestablish that moisture barrier that you have after the bath as well. Baths tend to be more stripping of the moisture in your skin than showers do.
Swimming in chlorine.
I would at least rinse off more often, as opposed to letting that chlorine sit on your skin.
If I could say one more thing here, I think it's really interesting in regard to the microflora of the skin and how important it is, as well as some of the immune cells that operate in the skin. And I wonder if you would speak to that point. That's one of the reasons you have to be careful about too much bathing, and that is you get rid not only the moisture and the oils in the skin, but you also get rid of those bacteria. And incidentally, you were talking about skin cancer. I read a while back, I think it's not real recent, but anyway, that there is a certain particular bacterial species, one of the staphylococci, that if it's present as part of the normal flora, it is cancer preventative.
Perhaps in the preparation for this, did you run across anything like that?
I'm not certain which species of staph that would be. I've not heard that.
Staph dermatitis.
All right. I will say, though, as you were saying, we have a balance of flora and bacteria on our skin when it's healthy. And when there are changes to our skin is too dry, or the pH of our skin is different because of different products that we're using, that can disrupt the flora of the bacteria. So like the candidiasis that we were talking about, that is an overgrowth of the candida bacteria. So whenever you disrupt that flora, then
One more thing that I think is fascinating, and that is that there are specialized cells in the epidermis that are part of the immune system.
Yes.
Those decline, though, as age goes on. Thank you.
Thank you. Very insightful.
And do you know, Helen, do they decline in number or just in function, or both, probably? Both. Yeah. Interesting point. I think the how often to bathe thing is a really interesting point. It's locked into the American psyche and from the last half of the last century, I think, that you must bathe every day. And turns out that's not healthy, not as healthy. It's not unhealthy exactly, but it can be detrimental in ways that you wouldn't recognize, and including the hydration of the skin. So great points. Any other itching questions?
Does anyone remember the word for itching that Dr. Chapman taught you?
So, yeah,
Good
yes.
job. Pruritus.
top of the class. Let's see. Yes.
You have all those wonderful big words. Early on in Dr. Chapman's presentation, you used a word that started with a T, about 6 letters long, that was for use after too much sunlight.
Oh, I think that's tretinoin.
Yes. And I was going to try to remember it and ask you when you got through, but by the time you got through, it was gone. Is there an over-the-counter name for tretinoin?
So tretinoin, so as we were discussing, it's a retinol agent. So there are certain medicines that are retinol agents that are over the counter, but they're less potent. Tretinoin is a relatively potent retinoid, and so that's typically prescribed by dermatologists. But so there are other agents, I'm sorry, ma'am, I didn't know your name, but she had mentioned trying. Retin A is what she
We were
said.
always familiar with the name Retin A, and this is just another form of that, the tretinoin, as far as I know.
Or retinol. Anything with that RETIN, those are all derivatives from vitamin A. So, and you can just find them, you can find them in the pharmacy in the over-the-counter section, but also just in the makeup section and the skincare section. There will be a lot of night creams have vitamin A in them, or retinol or retinoin in them. Yes, vitamin A is in carrots. I will say though, we're talking a lot about vitamin A, which is great, but I will just caution you against being super excited and going home and telling your grandchildren, you should be using this now to prevent. It's not a bad thing to use it now, but that vitamin A can be damaging if someone is pregnant, or if it's a male, if their partner is pregnant. So you have to stop using it whenever you are potentially getting pregnant. So I just wanted to put that out there in case you do want to go.
I might just mention while it's on my mind before I lose it. You know, the normal changes with aging are thinning of the skin, one of the normal changes. Another thing that can thin the skin and should be wary of is if you're given steroid cream to use on the face, use it for a very limited period of time, because chronic continuing steroid cream will thin your skin pretty bad, will damage your skin. So you don't want to use it. Yeah, I mean, if it's a week or two, that's one thing, but 6 months would not be a good thing. Okay, I'm sorry. Somebody had, yes, of course. How could I forget you?
I just wanted to recommend that you wear sunscreen every day, even if you're not going outside, because the rays that come through the glass are not good for your skin. Winter and summer.
Yeah, I guess if you're by the windows much, you know, I think you can make a case for I'm so little by the window, but it is a good point. You don't have to be outside to get the effects of it. And in the car, yes, absolutely, absolutely. Well, if there are no more questions, I want to thank you all for your response and your questions, your great questions, and thanks for being here. See you next month.